Now we're going to discuss drugs for Parkinson's disease. Parkinson's disease is a slowly progressive neurodegenerative disease, and more than 100 Americans face Parkinson's disease here in the US, making it only second to Alzheimer's disease. Some cardinal symptoms that you are going to notice are dyskinesias and achonesias. We're going to see resting tremors, rigidity, postural instability, and slowed movements. But additionally, including the motor symptoms, we may have patients that have non motor symptoms, and they may experience symptoms like depression, fatigue, sleep disturbances, as well as the other autonomic disturbances like urinary retention, incontinence, constipation, and dysphagia. You might note with some patients with Parkinson's, psychosis, and dementia as well. Years before any functional impairment develops, some patients experience early signs like the loss of smell, excessive salivation, clumsiness of their hands. They have worsening fine motor skills like really bad handwriting. They'll have bothersome tremors, slower gait, and even a reduced voice volume. Many symptoms first will appear in their middle ages and then progress relentlessly as they age. The underlying motor symptoms are caused by the loss of dopaminergic neurons in the substantia nigra. Although there's no cure, the drug therapies that we are going to talk about may help them maintain functional mobility over the years. They may also help to prolong the quality of life and even life expectancy. What causes the underlying motor symptoms that are characteristic of Parkinson's disease? Remembering that these are a group of disorders we call dyskinesias, disorders of movement. We have resting tremors, rigidity, postural instability. We have slowed movement, which we term bradykinesia. And in severe Parkinson's, we will have bradykinesia actually progress to akinesia, which is the complete absence of movement. And with patients with Parkinson's disease, this neurotransmission is being disrupted primarily at the brain's striatum. So let's look at this model. In A, you're seeing a normal um, physiologic balance of dopamine and acetylcholine being neurotransmitted so that there is a balance in the release of GABA, which controls movement. With uh, B, you see here during Parkinson's disease, we have the release of dopamine in the substantia nigra being released, but unfortunately, we have too much acetylcholine going unopposed. So, what does this mean? Dopamine is an inhibitory neuron, um, or it inhibits the neurons that release GABA, where acetylcholine will excite the neurons that release GABA. So, here in Parkinson's, if we have too much acetylcholine going unopposed because there's not enough dopamine, then GABA is going to get released. And too much GABA. So, this overactivity of the GABAergic neurons is contributing to the motor symptoms that characterize Parkinson's. And you're going to see this excessive stimulation of neurons releasing GABA, causing disturbed movements. We don't fully understand what causes the degeneration of these dopaminergic neurons. However, there's strong evidence that shows a connection with alpha synuclein proteins. And these are toxic proteins that are synthesized by the dopaminergic neurons. And under normal conditions, our alpha synucleins are able to rapidly be degraded. But as a result, um, we know that if it's degraded, it's not going to accumulate. So there's no harm that occurs. Degradation of alpha synuclein requires two other proteins, however. We need parkin and ubiquitin. Parkin is an enzyme that catalyzes the binding of alpha synuclein to the ubiquitin. When they bind together, alpha synuclein then can be degraded. But if there are any proteins here that become defective, whether it's alpha synuclein, parkin, or ubiquitin, Degradation of the synuclein can't take place, and this is what we need to get rid of. When this occurs, we're going to have an overaccumulation of alpha synuclein in our cell, and it's going to form neurotoxic fibrils. When they have autopsied patients with Parkinson, these fibrils have been visible and they refer to them as Lewy bodies. These are very characteristic of the Parkinson disease pathology. This failure to degrade alpha synuclein results from two causes, either a genetic vulnerability to the toxin itself in the environment or defective genes coding for all three proteins, which can be found in families with an inherited form of Parkinson's disease. However, with patients that you don't see a connection of family inheritance, environmental toxins can explain the inability for alpha synuclein to not be degraded. So, when we're trying to use pharmacologic treatments to help our patients, the therapeutic goal then is to reverse the neuronal degeneration or prevent further degeneration that does not exist. And this neuronal degeneration that we're talking about is the neuronal degeneration that causes this imbalance of dopamine and acetylcholine. The goal is to improve the patient's ability to carry out the activities of daily life and also to find the appropriate drug and dosage that's going to help our patient so that there is lessen interference of being able to work, to eat, to bathe, and all the other ADLs that they may be struggling with. Drugs benefit the patient primarily by improving their symptoms of bradykinesia, their symptoms of gait disturbance and postural instability. Also, we're trying to make it so that the tremors and rigidity that they're experiencing aren't as disturbing and disabling as they were without the medication. So, there are two different uh, classes or major categories of drugs that we can use. Now, given the neurochemical basis for Parkinson, so remembering we have too little striatal dopamine and too much acetylcholine, the approach then makes sense. It's pretty obvious. We need to give drugs that are going to restore that balance. So we might have to give dopaminergic agents so that we can promote the activation of dopamine receptors. This is levodopa. Or we're going to give anticholinergic agents, those that are going to prevent acetylcholine from forming or getting into the receptor specifically. And these anticholinergic agents we use specifically for Parkinson's disease, we're using benztropine. So here again, you are going to see drugs that are replacing dopamine like levodopa, carbidopa. And this is the first line drug or supplement that we use. And it's a dopamine agonist. It's promoting dopamine. But we also have other drugs like the anticholinergic drugs as well, which we talked about earlier. They're blocking the receptor for acetylcholine. But of those two groups, dopaminergic agents are far more widely employed. And you can see here on table 19.1 the drugs that act as dopaminergic drugs, and they have several mechanisms. Levodopa gets converted to dopamine. So remember L-dopa, and it activates dopamine receptors directly. But if we have drugs that inhibit the MAO or the monoamine oxidase B, this will prevent the dopamine breakdown. We also have drugs like amantadine, which promotes dopamine release and also blocks that dopamine reuptake into the neuron transmitter, excuse me. And the inhibitors of catechol O methyltransferase or COMT enhances the effects of levodopa by blocking its degradation. And remember, we talked a lot about this last week in the peripheral nervous system as it pertained to our anticholinergic drugs. In the next few slides, we're going to consider how we decide what drug to use. And with patients with mild symptoms, we can use monoamine oxidase inhibitors. And you can see them here, the selections that you can choose from. But for more severe symptoms, using levodopa combined with carbidopa tends to be the most effective option. We can also use dopamine agonists, but levodopa is going to be more effective. However, long term use carries a higher risk for disabling dyskinesias. So we're using it to help reduce dyskinesias, but long term use is also going to increase the risk for disabling dyskinesias. So keep that in mind. We also need to manage the motor fluctuations. So, when we are using levodopa, sometimes our patients have what we call off times. And off times are periods where they lose symptom relief by using the drug, and also we're having these drug induced dyskinesias. So, during the off times, we can switch over to dopamine agonists, or we can use the COMT inhibitors or the MAO-B inhibitors. So even though we can use these drugs to help manage the balance of dopamine and acetylcholine, we are still unsure if it's really providing neuroprotective effects with patients with Parkinson's disease. However, animal studies have shown, and they look pretty promising, regarding our MAO-B inhibitors. Similarly, dopamine agonists have demonstrated neuroprotective effects in lab studies as well. And for both drug categories, clinical studies in humans have been so far inconclusive. And so we are still trying to grow that body of research with drugs like levodopa to support the role for neuroprotection in patients. Levodopa by far is the most effective drug for Parkinson's disease, and it's only given in combination with carbidopa. And we will see at the beginning of treatment about 75% of patients that are put on levodopa for Parkinson's disease will have a 50% reduction in symptom severity. And it's so effective that if we give it to a patient that we suspect Parkinson's disease and they don't see a dramatic improvement, then we start to question whether we have made the right diagnosis in the first place. However, some things to consider that full therapeutic response may take several months to develop. So we might need to then educate our patients on the expectations. They're not going to see immediate improvement, but rather a steady increase of improvement over the first few months. However, in contrast to this dramatic improvement that we see with the initial therapy, long term therapy has been a little bit more disappointing. With the use of levodopa, symptoms are going to be well controlled during the first 2 years of treatment, but then it can sometimes return to pre treatment levels at the end of 5 years. And this is probably reflective of disease progression and not really about tolerance to the levodopa, but this is still unknown. So we're still trying to study this actually. Orally administered levodopa carbidopa combinations are rapidly absorbed from the small intestines. Food will delay its absorption, so make sure you talk about that with your patients. And neutral amino acids will compete with levodopa for that intestinal absorption and will also um, compete with the transport across the blood brain barrier. Levodopa crosses this barrier, which means that there is an active transport system. And so the system is not transporting dopamine. Also, dopamine has such a short half life in the blood that it would be impractical to use it even if it could cross the blood brain barrier. Going with the neutral amino acids competing, we also have to look at high protein foods, which also will reduce the therapeutic effects. So let's look a little bit more deeply into the acute loss of effect and how we would deal with that as a provider. So we might see two different patterns. We might see a gradual loss and an abrupt loss. With the gradual loss, or what we call a wearing off, usually this is near the end of the dosing interval. And simply, this just tells us that the drug levels that we have prescribed are not giving the therapeutic effect. So we're at a sub-therapeutic effect now. So wearing off can be minimized three ways. We can shorten the dosing interval, or we can give the drug that prolongs levodopa's plasma half-life, like entacapone. The other thing that we can do is that we can give a direct acting dopamine agonist instead. However, with this abrupt loss, it really is this off and on phenomenon, and it occurs anytime during the dosing interval, even when drug levels are high in the patient's system, and they last from minutes to hours. Over the course of treatment, these off periods are likely to then increase over time in both intensity and frequency. Drugs that can help reduce these off times, they are the drugs that are listed on the table 19.2, and we're going to talk about them as well. Also, educating your patient to avoid high protein meals may also help because it will lessen the opposition of intestinal absorption. Here we are looking at table 19.2. These are the drugs for motor complications of levodopa therapy. And you can see that we can use during the off times, we can use a COMT inhibitor, entacapone, or we can use the MAO-B inhibitor, rasagiline. We also could use, if those are not effective, these are the drugs that are probably, possibly effective as well. And we can also use amantadine, which is a dopamine releasing agent. And if we notice that there is levodopa induced dyskinesia, we can then stop the levodopa for a while and use amantadine. Now we're going to look a little bit more closely at the mechanism of action of levodopa. Specifically, we know that it increases dopamine synthesis and it enters the brain via active transport through the blood-brain barrier. When it's inside the brain, the drug undergoes an uptake into the remaining dopaminergic nerve terminals that remain inside the striatum. But after this uptake, levodopa, which has no direct effect on its own, is going to be converted back to dopamine, which is the active form of levodopa. And as dopamine, levodopa is going to restore the proper balance between dopamine and acetylcholine, helping to regulate the release of GABA. We are also going to see that levodopa, this conversion of levodopa back to dopamine, is going to be seen in the next slide, and it's showing an enzyme that catalyzes the reaction. And this is called decarboxylase. It removes the carboxyl group from levodopa. We're also going to note that there's activity of decarboxylase, which is enhanced by vitamin B6 or pyridoxine. The most common side effects of levodopa are really dose dependent. In older patients, we're going to see that they're going to be more sensitive to these adverse effects. Most patients are going to experience nausea and vomiting, and this usually happens early on in the treatment process. The cause is because of the activation of dopamine receptors, not only in the striatum where we're trying to have them work, but also in the chemoreceptor trigger zone or the CTZ of the medulla. And when this gets triggered, nausea and vomiting can also ensue. This can be reduced, however, if we give levodopa in low initial doses and we give them with meals, remembering that we can use food to delay that absorption. However, over time, when the patient starts to use levodopa over time, they may not have these same symptoms of nausea and vomiting, and you don't want to have them use levodopa with food then because it could reduce that therapeutic effect over time. Okay, so we can use it to our advantage when we need it to delay or to reduce those episodes of nausea and vomiting. But then after a while, when the nausea and vomiting starts to lessen, we won't tell the patient to take levodopa with their food. It's going to decrease the absorption overall. Now, giving additional carbidopa can help reduce nausea and vomiting as well. Well, why? We don't really know, but studies show that peripheral decarboxylase is saturated by carbidopa, and so this may help to reduce the signs and symptoms of nausea and vomiting, but we're still not sure. But patients receiving less than this amount of carbidopa, less than 70 to 100 milligrams a day, are more likely to experience the nausea and the vomiting. Some other adverse side effects in terms of cardiovascular effects are postural hypotension. And this is common again in the early treatment phase. We don't know the mechanism which is causing the postural hypotension here, but it can be reduced by increasing the intake of salt and water into the patient's diet. We can also use an alpha adrenergic agonist to help as well. The conversion of levodopa to dopamine in the periphery can produce this excessive activation of beta 1 receptors in the heart. That's the theory. And so dysrhythmias can result, especially with patients that have already an underlying heart disease. Psychosis develops in about 20% of patients, and the symptoms usually are visual hallucinations. They will start to have vivid dreams or even nightmares at night. And some patients will experience paranoid ideations, fears of personal endangerment. They'll have a sense of persecution and they start to feel like they're being followed or spied on. Activation of dopamine receptors is thought to be involved in this development of psychosis. It can also be reduced by lowering the levodopa dosage and also understanding though, as you reduce the levodopa, then you're also reducing the benefits from using levodopa. So it is a balance, it's a risk and benefit balance. The treatment of levodopa induced psychosis can be you can use first generation antipsychotics, um, but it becomes problematic because the agents can decrease psychologic symptoms, but then they can then further intensify symptoms of Parkinson's disease because they will start to block the receptors for dopamine. And then now we're having that imbalance again of dopamine and acetylcholine and that release of GABA. So, when you use first generation antipsychotic agents for schizophrenia, the biggest problem really is Parkinsonian side effects. And we saw that when we went over the antipsychotic medications. We call this extrapyramidal symptoms or EPS. They are um, fighting for that receptor. So instead of using a first generation antipsychotic and having to balance the symptoms of Parkinson's and psychosis, there are two second generation antipsychotics, clozapine and quetiapine. And you can use these successfully to manage levodopa induced psychosis. Okay, so unlike the first gen antipsychotic drugs, we don't have as much, very little to no blockade of dopamine receptors within the striatum. So we're not going to see the EPS or extrapyramidal symptoms here. Other adverse side effects that are seen with levodopa, we might have several CNS effects that range from anxiety to agitation. We also might have memory or cognitive impairment. We talked about nightmares, but also patients can experience insomnias as well. Some patients on levodopa experience problems with impulse control, and this is going to change their behaviors. It can make them um, have a propensity for gambling, promiscuity, binge eating, or even alcohol abuse. Now let's talk about the ironic adverse effect. So we treat with levodopa to improve movement disorders, but we can also cause dyskinesias as well. About 80% of our patients will develop involuntary movements within that first year. And these dyskinesias just become very annoying. They are like the head bobbing, the tics, the grimacing. Other patients, though, will experience disabling dyskinesias, like rapid involuntary jerking. They might even have very slow involuntary writhing movements as well. And as these dyskinesias develop, just before or soon after that optimal levodopa dosage has been achieved, it can be very discouraging. Dyskinesias can be managed, though, in three ways: drug therapy, surgery, or we can use electrical stimulation. So, first approach would be the dosage of levodopa. We can actually reduce it just below that threshold where we're not seeing the unwanted dyskinesias. However, as we reduce the dose, then the other Parkinson's disease symptoms will start to reemerge. Remembering that we can also use amantadine, which we discussed a little bit earlier, but we're going to discuss again a little bit later in this presentation as well. We can also use that to oppose the levodopa induced dyskinesias. Now, if all these measures fail with pharmacotherapeutics, then surgery or electrical stimulation are options that we can start to discuss with our patients. Other adverse effects to talk to your patients about is the darkening of their sweat and their urine. Although it does look dark, it is harmless. And then we have seen some studies that suggest that levodopa can activate malignant melanoma. And so, until we know more information, it's just very prudent of us to perform a careful skin assessment for patients taking levodopa. We have just a few more slides talking about levodopa. First, let's go into the drug interactions. We already know that first generation antipsychotic drugs will fight or block the receptors for dopamine in the striatum, and then therefore we are going to see those extrapyramidal symptoms, and it will decrease the therapeutic effects of levodopa. In addition, using levodopa with MAO oxidase inhibitors can cause a hypertensive crisis, especially if that patient is taking a non selective inhibitor of the MAO. So, how does this occur? Levodopa elevates neuronal stores of dopamine and norepinephrine by promoting the synthesis of both of those transmitters. Because intraneuronal MAO serves to inactivate dopamine and norepinephrine, that inhibition of MAO will allow that elevation of neuronal stores. And then the transmitters will accumulate and the stores grow even larger. Because dopamine and norepinephrine both promote vasoconstriction, that release of the of these agents are going to cause massive vasoconstriction, thereby causing a rise in the blood pressure that can get dangerously high. So, to avoid this, if you have a patient on a MAO inhibitor, but you are thinking about starting levodopa, the MAO inhibitor needs to be withdrawn at least 2 weeks before giving levodopa. And then with anticholinergic drugs, just as we've talked about before, excessive stimulation of cholinergic receptors contributes to dyskinesias of Parkinson's disease because we are promoting the GABA in the striatum, or after the striatum, the dopamine in the striatum, we are then further promoting GABA, causing the motor disruptions. So, blocking the receptors by using acetylcholinergic agents are going to enhance the responses to levodopa. Additionally, we see that pyridoxine or vitamin B6 can also affect the use of levodopa. And so, using vitamin B6 should be limited. It can accelerate the decarboxylation of levodopa at the periphery. However, because levodopa is now always combined with carbidopa, which is a drug that suppresses decarboxylase activity, this potential is no longer of real clinical concern. But this is answering your question of why levodopa is always prescribed with the use of carbidopa. By far, using the combination of levodopa and carbidopa together is the most effective therapy for Parkinson's disease. And there are some disadvantages of carbidopa, however. By itself, it has no adverse effect on its own. Any adverse responses that you have from carbidopa, levodopa, it's the result of the potentiality of the effects of levodopa. So when levodopa is combined with carbidopa, we actually will have a reduction in these effects. Abnormal movements and psychiatric disturbances can occur sooner, though, and can be more intense when we use levodopa alone. So please consider prescribing the levodopa carbidopa combination. We're going to move on to a different classification of medications for Parkinson's disease. These are also considered first line drugs for Parkinson's, dopamine agonists. And the beneficial effects will result from this direct activation of the dopamine receptors in the striatum. This is used again for patients with mild to moderate symptoms. These can be first choice drugs for mild to moderate symptoms. And although dopamine agonists are less effective than that of levodopa, they still have some advantages. Specifically, in contrast to levodopa, we're not going to have this dependency on enzymatic conversion to become active. Also, they're not converted to potentially toxic metabolites and they don't compete with dietary proteins for uptake from the intestines or transport across the blood brain barrier. Additionally, when used long term, these dopamine agonists, they actually have a lower response or lower incidence to response failures and are less likely to cause those disabling dyskinesias that we saw with levodopa. However, dopamine agonists do cause some other serious side effects, especially hallucination. We have patients that suffer from daytime sleepiness and postural hypertension as well. As a result of this, we usually reserve these medications, these dopamine agonists, for patients that are younger and who can tolerate the side effects better, which is typical. Younger patients will be able to tolerate this better than older patients. The dopamine agonists are going to fall into two different groups, and we're going to go over both of them here. The first ones are derivatives of ergot, and this is an alkaloid found in plants. And then we have the derivatives that are non-ergot. The non-ergot derivatives are going to be highly selective for dopamine receptors. In contrast, though, the ergot derivatives are less selective. Additionally, when we activate the dopamine receptors, these drugs can cause mild blockage of serotonergic and alpha adrenergic receptors. Because of their selectivity, the non ergot derivatives actually will cause fewer side effects than those of the ergot derivatives. Non ergot dopamine agonists like Mirapex can be used alone in early Parkinson's, but also can be used in combination with levodopa in the advanced stages. Overall, it will take several weeks to develop maximal benefits from using this drug. Some adverse effects that can be seen with monotherapy are nausea, dizziness, daytime somnolence, insomnia, constipation, weakness, and hallucination. When used in combination with levodopa, you're going to see those adverse effects from the levodopa, like orthostatic hypotension, dyskinesias, and an increase in hallucination. When combined with levodopa, the drug can reduce fluctuations in motor control and may permit a reduction in the levodopa dosage, which is great because if you're not using such a high dose of levodopa, we can maybe reduce the incidence of the off times or the increase of dyskinesias. Compared with levodopa, Mirapex is less effective at controlling the motor symptoms of Parkinson's, but it's also less likely to cause these motor fluctuations. So that would be your rationale for wanting to use a non-ergot dopamine agonist. Additionally, this medication is approved for patients with moderate to severe restless leg syndrome, which is a sensory motor disorder where patients will feel this unpleasant leg sensation and just a constant urge to move around their legs to try to ease that discomfort from the restless leg syndrome. We also want to know, in addition to these adverse effects here that have been reported, we see that patients also may have sleep attacks. And this is an overwhelming and irresistible sleepiness that comes on without any warning. And these sleep attacks should not be equated with the normal sleepiness that can occur when just taking dopaminergic agents in general. We also know that with the use of Mirapex, like other non ergot dopamine agonists, it has been associated with impulse control disorders. So we might see compulsive gambling, shopping, binge eating, and hypersexuality that can be exhibited with patients under the care of non ergot dopamine agonists. Risk factors for using this drug include younger adulthood, if you have a family or personal history of alcohol abuse, a personality, a trait called novelty seeking, where you're just looking for the next fix, characterized by impulsivity, quick temper, low threshold for boredom, you may not be a candidate for this medication. Also, you need to screen patients for compulsive behaviors and underlying psychiatric disorders. Requip is another non-ergot dopamine agonist, both selective for D2 and D3 receptors as well, and it does share the same indications previously mentioned with the other drug. We can also use this for restless leg syndrome as well. Like our other drug, non-ergot dopamine agonist here, Requip, can be used as monotherapy and then adjunctively with levodopa for advanced stages. Much like our other common side effects, we have nausea, dizziness, somnolence, and hallucinations, but rarely sleep attacks will occur when using Requip as opposed to Mirapex. When you use this drug in combination with levodopa, the side effects are going to be pretty much the same. Um, and it's coming from the use of levodopa, the postural hypotension, hallucinations, and dyskinesias, and you're going to see that compulsivity and behavior changes as well. And another important aspect of this drug is that you would not want to use it for or use it during pregnancy. Neopro is another non-ergot dopamine agonist, and we will use it again from the early to advanced stages. And this drug can also manage the moderate to severe cases of restless leg syndrome as well. The most common side effects that you're going to experience with Neopro are the CNS and neuromuscular system effects like sleepiness, dizziness, headaches. We might even see dose related hallucinations and dose related dyskinesias as well. It is a drug that can be combined with levodopa as well, and you might see orthostatic hypotension and peripheral edema may occur with the use of this medication. Though nausea and vomiting are going to be the most common side effects, especially when you're using this drug in the beginning stages. Some patients do develop skin reactions to this drug and even excessive perspiration called hyperhidrosis. Non-ergot dopamine agonists also include apokine or apomorphine, and this drug is going to be different than the other ones we've talked about because it's not indicated for routine Parkinson's disease management. We're only going to use this for the acute treatment of the off episodes, and this is when we have patients that are experiencing the hypomobility that can occur with advanced stages of Parkinson's disease. Now, it is a derivative of morphine, but it's not going to have the opioid effects like analgesia, euphoria, and respiratory depression. When tested in patients experience at least 2 hours of off times a day, this actually produced a 62% improvement of their Parkinson's disease symptoms. Benefits were sustained during 4 weeks of use. There are some common and adverse effects that we need to talk about, and usually it's going to be injection site reactions. Because this drug is not given PO and injected, we might have some skin or injection site reactions. However, we do see hallucinations, yawning, drowsiness, dyskinesias, rhinorrhea, nausea, and vomiting as well. In some clinical trials, there was a 4% incidence of cardiovascular events like angina, myocardial infarction, and even sudden death. And with less than 2% of patients in clinical trials, we saw postural hypotension and fading that occurred as well. Now, very similar to the other dopamine agonists that we talked about, apomorphine can pose a risk for daytime sleep attacks also. Something that's a little bit different, in addition to the hypersexuality that we see in the other non-ergot dopamine agonists, this drug can also enhance erection. So in Europe, they use it to treat erectile dysfunction as well. To prevent nausea and vomiting during clinical trials, what they did was they would prescribe an antiemetic 3 days before prescribing the apomorphine. And there are certain antiemetics that should not be used. The two classes of antiemetics that cannot be used are the serotonin receptor antagonists like Zofran. And we don't want to use the dopamine receptor antagonists like Compazine because basically you're doing the opposite of what this dopamine agonist is supposed to do. So what you would use instead is the antiemetic called Tigan, trimethylbenzamine. And this is the choice antiemetic to give. Why don't we want to use serotonin receptor antagonists? This is going to increase the risk for orthostatic hypotension, which they already have because of the medication itself. And really, it's not going to have any effect on the nausea. Dopamine receptor antagonists are going to decrease the effectiveness of the apomorphine because it's a drug in the dopamine agonist classification. Ergot derivatives are not tolerated as well as the non-ergot derivatives, and therefore their use is pretty limited. The side effect profiles of these ergot derivatives differs from that of the non-ergot agents because in addition to activating dopamine receptors, ergot drugs can also cause a mild blockade of the serotonergic and the alpha adrenergic receptors. Now we're going to move into the COMT inhibitors. There are two COMT inhibitors that are available, entacapone and tolcapone. And with both of these drugs, the benefits derive from the inhibition of the metabolism of levodopa in the periphery. Remember, we're trying to work on inhibiting the catechol O methyltransferase that will break down dopamine. And these drugs have no direct therapeutic effect on their own. We do know that entacapone is safer and more effective than the other medication, and this is why that drug is preferred. Entacapone, or Comtan, is selective reversible inhibitor of the COMT, and it's indicated only for the use with levodopa. So like carbidopa, we are going to use this medication to inhibit the metabolism of levodopa in the intestines and the peripheral tissues. However, it differs because it's inhibiting different enzymes. Carbidopa inhibits the decarboxylases, which are going to break off that carboxyl connection, whereas entacapone is going to inhibit on the COMT. By inhibiting COMT, this drug is going to prolong the plasma half-life of levodopa, therefore prolonging the time that levodopa is available to the brain. Additionally, it can increase levodopa's ability by a second mechanism. If we inhibit the COMT, this medication will decrease the production of levodopa metabolites that are competing with levodopa for transport across the blood-brain barrier. The adverse side effects of this drug are very similar to the other drugs we've talked about because it's resulting from the increasing levodopa levels. We may see dyskinesias, orthostatic hypotension, nausea, hallucinations, sleep disturbances, and impulse control disorders, much like the other drugs. They can be managed by decreasing the dosage of levodopa with the use of entacapone. This drug should never be stopped abruptly. However, when you do so, it can result in significant worsening of symptoms. Using this drug itself is responsible for fewer adverse effects. And the most common side effects, if you were to use this drug by itself, are vomiting, diarrhea, and constipation. And also, it can discolor your urine as well. Remembering, though, that we do want to use this in conjunction with levodopa. Another consideration of this drug is how it interacts with other drugs. Because it inhibits the COMT, entacapone can, in theory, increase levels of drugs that are also metabolized by COMT. So in addition to levodopa, these drugs include methyldopa, which we use for antihypertensives. It can also compete with dobutamine, which is an adrenergic agonist, and we can also compete with isoproterenol, which is a beta adrenergic agonist. So in combination with these drugs, what will happen? We will see an increase of effect. So a reduction in the other dosages may be needed. Tasmar is another COMT inhibitor used only in conjunction with levodopa, and only if the other agents, which are considered safer, are not effective. So, as with entacapone, benefits derive for inhibiting levodopa metabolism in the periphery and prolonging the availability of levodopa. And when we give it with patients that are already taking levodopa, this can improve motor function and may also allow a reduction in the dosage of levodopa. But for many patients, this drug reduces the wearing off effect that can occur with levodopa. And so it's really going to extend the effects of levodopa for as much as like 3 hours a day. However, it is, even though it is effective, it can be considered potentially dangerous. And this is why it's not used as a first line drug. We have seen deaths from liver failure, and also because it carries a serious risk, it should be reserved for patients who can't be treated or treated adequately with any of the other drugs. And it should be limited to 3 weeks in the absence of a beneficial response. Some adverse effects, like we talked about, is the liver failure, and it can cause severe hepatocellular injury and sometimes even fatal injury. And because of this risk, there is a black box warning that's mandated by the FDA regarding liver failure. We might see, and what we need to inform our patients to be aware of is the emergent liver dysfunction signs and symptoms like nausea, fatigue, lethargy, anorexia, jaundice, and dark urine. And we want to instruct our patients to to report these symptoms immediately. And any patient with already a pre-existing liver dysfunction should not take this drug. If a patient is seen to have new liver dysfunction on Tasmar, then they should never take this drug again once it's been discontinued. It will increase the risk for hepatotoxicity and, again, not only liver injury, but liver failure, which can lead to fatality. So, what labs would you want to monitor? Obviously, liver enzymes are going to be required, like ALT and AST, and you want to get a preliminary value and also every 2 weeks for the first year of using this medication. And then after that, every 4 weeks for the next 6 months. And then every 8 weeks thereafter for the longevity of the use of this medication. And if you ever see ALT or AST levels exceeding the upper limit of normal, it needs to be discontinued right away. And you need to treat the liver injury if possible and never put the patient on this medication again. Now we're going to look at the combination drug sold as Stalevo, and this is levodopa, carbidopa, and entacapone all together. And it is a fixed dose combination. And just as we discussed earlier, both carbidopa and entacapone inhibit the enzymatic degradation of levodopa, and it's going to enhance the therapeutic effects. This triple combination is more convenient than taking a levodopa carbidopa and then now taking entacapone separately. So your patients only need to worry about taking one medication. It's an immediate release tablet, and it only is provided in specific strengths, which you can go back to your book to refer to in table 19.4. But for patients who need more flexibility in their treatment, they should not be treated with Stalevo because they may not need all three medications. This last classification of drugs are the MAO-B inhibitors, and these are also considered first-line drugs for Parkinson's disease, but the benefits are often pretty modest. However, when combined with levodopa, we can help with the wearing off effects that occur with the use of long-term levodopa. Selegiline was the first MAO-B inhibitor approved for Parkinson's disease, and we can use it as monotherapy or with levodopa as well. However, again, we only see modest improvement in motor function. We can use it to treat patients not only for the symptoms of Parkinson's disease, but if we're able to diagnose Parkinson's disease early enough, we can use it to delay the progression of Parkinson's disease and further delay the need for using levodopa. When used alone, the principal adverse effects of this medication are going to be insomnia, and this is presumably because of the metabolism that results in the CNS excitation. Insomnia can be minimized if we give the last daily dose no later than noon. Other adverse effects include orthostatic hypotension, dizziness, and GI symptoms. Patients that are taking the oral dose of selegiline can experience irritation of the buccal mucosa as well. and the oral doses come in oral disintegrating tablets or ODTs. Unfortunately, with the use of this medication, we see a dramatic decline in benefit over 12 to 24 months. Now we're going to talk about Rezagoline, which is another drug that falls under the classification of a MAO-B inhibitor, and we use it for Parkinson's disease. Much like selegiline, it is a selective, irreversible inhibitor of the MAO-B. And why would we want to use this drug? Well, the benefit is going to derive from preserving dopamine in the brain. And even though it is approved for initial monotherapy, we can use it again in combination with levodopa. It's pretty similar to the last drug, selegiline, as well. The benefits are going to be modest. The difference is that this drug is not converted to amphetamine or methamphetamine. Some adverse effects to think about when using as monotherapy, you will have the common symptoms like headache, arthalgia, dyspepsia, depression, and flu-like symptoms. But unlike selegiline, you're not going to have insomnia. When Rezagoline is combined with levodopa, however, you're going to see the side effect profile increase because of the levodopa. And then the most common additional reactions are going to be the dyskinesias, nausea, orthostatic hypotension, constipation, weight loss, and hallucinations. But like selegiline, this drug, Rezagoline, may pose risks for hypertensive crisis as well. And this is because at higher doses, we're also inhibiting the MAO-A. So it becomes a MAO-A inhibitor. Rezagoline may increase the risk for malignant melanoma as well, and so periodic monitoring of your patient's skin is recommended. Rezagoline also has several drug interactions. Like selegiline, Rezagoline can intensify the adverse response that levodopa can bring on. If the patient develops dopaminergic side effects like dyskinesias or hallucinations, then we need to reduce the dosage of levodopa, not the Rezagoline. We also have to consider the CYP1A2. Blood levels of Rezagoline can be raised by drugs like ciprofloxacin that inhibit the CYP1A2, which is a hepatic enzyme that inactivates Rezagoline. So, with patients that are taking drugs that are CYP1A2 inhibitors, the daily dosages of those drugs need to be reduced. Otherwise, we're going to lessen the effects of Rezagoline. For patients that are taking MAO inhibitors, combining Rezagoline increases the risk for hypertensive crisis. So, at least 2 weeks before you start your patient on Rezagoline, you should discontinue the MAO inhibitor. With sympathomimetic drugs like amphetamines or ephedrine, we might want to increase the risk. It will increase the risk for hypertensive crisis as well. And so we need to consider not prescribing sympathomimetics with Rezagoline. In terms of tyramine containing foods, which we spoke about previously, these foods will increase the risk for hypertensive crisis as well. When combining Rezagoline with several antidepressants, we might also have adverse effects. When we prescribe Rezagoline and a patient is taking an SSRI or serotonin norepinephrine reuptake inhibitor, or even a tricyclic antidepressant, this can also pose a risk, specifically for hyperpyrexia and death. So we want to discontinue these drugs at least 2 weeks before starting Rezagoline as well. There is a specific SSRI, though, that you need to discontinue at least 5 weeks before starting Rezagoline, and that's fluoxetine. Combining rosogline with meperidine, methadone, and tramadol may pose a risk for serious reactions as well, including coma, respiratory depression, convulsions, and hypertension. You want to separate these two drugs by at least 2 weeks. With dextromorphan, we want to make sure that we are considering that this can cause a risk for psychosis and bizarre behaviors. So, combining rosogline and dextromorphan is also not recommended. And the last drug that we'll talk about is cyclobenzaprine. This drug is structurally related to TCAs, so it should also be avoided. Amantadine is a drug that usually gets a good response within a couple days. However, this response is going to be less profound than what you would have seen with levodopa or dopamine agonists. And although you see a response really quickly, it starts to diminish within the first 3 to 6 months. Now, amantadine was first developed as an antiviral agent and then later found to be effective for the use of Parkinson's disease. And this is largely because of the mechanism of action. It's thought to inhibit the dopamine reuptake. It's also stimulating the dopamine release. It blocks cholinergic receptors, and due to the antagonism of N-methyl D-aspartate receptors, or the NMDA, we see some benefit. And lastly, there's a blockade of the glutamate receptors. Accordingly, amantadine is not considered a first line agent because we're not going to have the same results as levodopa or a dopamine agonist. Yet, this drug can be helpful for managing those off times or the dyskinesias that are caused by levodopa. When the effects or if the effects diminish, we can restore by increasing the dosage, or we can discontinue the drug for several weeks and then start it back over again. Some adverse effects to consider with amantadine are CNS effects, largely like confusion, lightheadedness, and anxiety, but you might also see peripheral effects as well. And this is thought to be due to the muscarinic blockade. So you will see those anticholinergic effects like blurred vision, urinary retention, dry mouth, and constipation, and usually all generally mild symptoms if you're using amantadine alone. But if you use amantadine and you might be also taking an anticholinergic agent, then you're going to see an increase in not only the CNS effects, but also additionally, the peripheral responses like those anticholinergic effects resulting from the muscarinic blockade. Patients taking amantadine for a month or longer can also develop what is called libido reticularis, and this is a condition characterized by mottled, discolored skin. Libido reticularis is benign and generally subsides after you stop the amantadine. We're moving on to the centrally acting anticholinergic drugs that were first used for Parkinson's in 1867. And this makes them the oldest medications for the use of Parkinson's disease. These drugs alleviate symptoms by working on the muscarinic receptors. We're going to block those receptors in the striatum and improve then balance between the dopamine and the acetylcholine. Anticholinergic drugs like the centrally acting muscarinic receptors or blocking receptors are going to reduce tremor and possibly rigidity, but it's not going to help with the bradykinesia. These drugs are less effective than using levodopa or using the dopamine agonist. However, these are well tolerated. Today, these drugs are used as second line therapy for tremors. They're most appropriate for our younger patients with only mild symptoms, and they should really be avoided in older patients because of the CNS side effects. For those patients that can't tolerate these CNS side effects, they also should not be used. The side effects we're talking about are sedation, confusion, delusions, and hallucinations. Although these drugs are somewhat selective for the cholinergic receptors in the CNS, they can also block cholinergic receptors in the periphery as well. And because of that, you will see or you will see like cholinergic side effects like dry mouth, blurred vision, photophobia, urinary retention, constipation, and tachycardia. These effects are usually going to be dose limited. So, if you do see these effects, you can lower the dose of these medications. When we block the cholinergic receptors in the eye, we might even precipitate or even aggravate an existing glaucoma. So, intraocular pressure needs to be measured periodically while taking these medications. Anticholinergic agents used often are going to be the benztropine, which is also called cogentin, and we also use trihexyphenidyl, which was available as Artane. Providers need to be aware that if these anticholinergic drugs are discontinued abruptly, sometimes the symptoms of Parkinson's disease will be intensified pretty quickly. The last series of slides are going to be focusing on the non motor symptoms and how to manage them. So, in addition to all the motor symptoms that we are seeing with 90% of patients, we're also going to see non motor symptoms. And these are notably due to the autonomic disturbances. We'll see sleep disturbances as well, depression, dementia, and psychosis. There are two evidence based guidelines that help us to determine how to evaluate and treat the depression, psychosis, and dementia in Parkinson's disease. With the autonomic system, that disruption of function can produce a variety of symptoms like constipation, urinary incontinence, drooling, orthostatic hypotension, cold tolerance, and erectile dysfunction. And the intensity of these symptoms are going to increase in parallel with the intensity of the motor symptoms as well. So we can, if there's no other contraindications, we can treat each of these symptoms specifically. Erectile function can be managed with the use of sildenafil or Viagra or any other inhibitor of that type V phosphodiesterase. We talk more about this in chapter 53. Orthostatic hypotension can also improve by increasing your salt and fluid because now um, we can, you know, by default raise up the blood pressure. But we can also take drugs like a mineralocorticoid as well. Urinary incontinence can improve with the use of oxybutynin, or we can choose a peripherally acting anticholinergic drug. Constipation can be used by movement, getting, or can be, treated by including additional movement, regular exercise, maintaining adequate fluid and fiber. However, maintaining adequate exercise may be an issue with our Parkinson's patients. So, getting an adequate intake of fluid and fiber tends to be a better option. And you can also use an osmotic laxative like polyethylene glycol and perhaps even a stool softener like Docusate. Parkinson's disease is also associated with excessive daytime sleepiness, sometimes referred to as EDS. We also might see periodic limb movements when we're sleeping and also insomnia. Patients will have either difficulty falling asleep or staying asleep. So, with the excessive daytime sleepiness, some patients will respond to modafinil, which is a non amphetamine CNS stimulant. For the periodic REM movement that happens during sleep, levodopa carbidopa should be considered. You can also use a non ergot dopamine agonist. Remember, that can help with the symptoms of like restless leg syndrome. So, this could also help with this limb movement during sleeping. Insomnia can be improved by using levodopa carbidopa and melatonin together. And the combo levodopa carbidopa can help by reducing the motor symptoms that impair, falling asleep in the first place. Melatonin specifically helps people feel like they are sleeping better, even though the objective isn't really, sleep quality, but it will improve. Because up to 50% of Parkinson's patients will develop depression, we need to consider how we can treat this debilitating disease. And according to the guidelines, there's only one drug, which is amitriptyline, that has proved to be effective. Unfortunately, this drug is a TCA, and it's going to have anticholinergic effects that can exacerbate dementia as well as the antiadrenergic effects that exacerbate the orthostatic hypotension. They're already going to be at risk for this with their levodopa carbidopa combination. Data for other antidepressants like SSRIs and also bupropion are insufficient right now, so they are not to be used for Parkinson's disease. They don't show efficacy. Unfortunately, up to 40% of Parkinson's disease patients will also develop dementia. And according to the guidelines, you can consider treating with two different drugs. You can either use donepezil or rivastigmine. And these drugs, remember, are cholinesterase inhibitors, and we use them for Alzheimer's disease. And in patients with Parkinson's, these drugs can actually produce a modest improvement in cognitive function without causing significant worsening motor symptoms. Psychosis also needs to be treated, and it is usually caused by the drugs taken to control motor symptoms. And most of these drugs, like levodopa, the dopamine agonists, amantadine, and anticholinergic drugs, can cause hallucinations. If psychosis develops, dopamine agonists, amantadine, and anticholinergic drugs need to be withdrawn as soon as possible. The dosage of levodopa should be reduced to the lowest effective amount. If you do need an antipsychotic medication, a first generation antipsychotic again should be avoided because these drugs are going to block the receptors for dopamine, and then we're going to intensify the motor symptoms that we've been working so diligently to reduce. According to the guidelines, the recommendation is considering two second generation antipsychotics. Again, we will use second generation antipsychotics. We're using clozapine or quetiapine. Because clozapine can cause agranulocytosis, many clinicians are going to prefer the use of quetiapine. The clinical guidelines recommend against the routine use of olanzapine, which is another second generation agent. So, really be careful and remember the use of only clozapine or quetiapine.